Hello dear friends, I'm Emeko Gönju and I am recording this presentation from Berlin and I am sending you my best wishes from here and I would like to thank the organizing committee for their kind invitation. I will be speaking about urticaria in pregnant and breastfeeding women. So pregnancy is a very precious immune state where the mother needs a degree of immunosuppression to tolerate the foreign fetus, while it must maintain sufficient immune function to fight off infections. So then there comes some specific immune adaptations which protect the mother from harmful pathogens while allowing for tolerance to fetal antigens. And here you see the immune changes during the immune inflammatory response changes during pregnancy. In the early and late stages, there is a pro-inflammatory reaction that is generally dominated by Th1 and Th17 cells and inflammation, while in the mid-gestation, around the second trimester, there is a shift from Th1, Th17 to Th2 spectrum, and also T regulatory cells peak so that they prevent the rejection of the fetus. So, in general, Th1 dominates first and third trimester, while Th2 responses dominate the second trimester. And we see some corresponding clinical outcomes for this. For example, asthma and atopic dermatitis tend to worsen at the second and third trimester, while improvement of autoimmune diseases are expected, such as rheumatoid arthritis and multiple sclerosis. And there is also a propensity to infections during pregnancy. But what happens to chronic urticaria during pregnancy? We really didn't know the answer to this question, even though chronic urticaria is a 70% female dominant disease, and also it is more commonly seen in the reproductive age. But despite that, we didn't know what's happening to our pregnant patients during pregnancy. So we wanted to understand if urticaria gets better, gets worse, is it with worse outcomes of pregnancy. So together with other UCare centers. UCare center means Urticaria Centers for Reference Excellence. So we collaborated together and did the PREG-CU project, which evaluated the changes in disease activity, treatment patterns, and outcomes in patients with chronic urticaria during pregnancy. So our first paper is published in Allergy, and it showed that from out of 288 pregnant chronic urticaria patients, so this also shows the power of UCare centers. When you collaborate, then you have a high number of patients, and then you have a nicer and more impactful publication. So what we saw is chronic urticaria gets better in half of the patients during pregnancy. However, 1/3 of patients had the worsening of their chronic urticaria during pregnancy, and 20% stated that their urticaria did not change. However, 10% of the patients required emergency care because of their urticaria exacerbations. So still, there were some serious cases. And the exacerbations typically occurred in the first and third trimester, where we hypothesized that maybe the increase in Th1 and Th17 responses might be associated with the exacerbation of urticaria. And also we saw that angioedema frequency dropped from 35% to 17% in CSU patients. So it was also a nice finding that emergency referrals, while they still exist, but they were lesser than the routine patients who are not who do not have urticaria and reported in other studies. So in general, urticaria showed an improvement during pregnancy. But who worsened? So we checked for risk factors for the worsening of urticaria, and we saw that patients who had a lower disease activity before pregnancy tended to get worse during pregnancy. Who didn't have angioedema had worse worsening of urticaria during pregnancy. And also, if the patient worsened in their previous pregnancy, she worsened again in this current pregnancy. And also, of the patients who improved during pregnancy, half of them also worsened after delivery. That really shows that during pregnancy, some inflammatory or hormonal changes really help with the course of chronic urticaria. And there was the second publication from the PREG-CU study that showed the treatment patterns and outcomes in patients with chronic urticaria during pregnancy. So we found that most of the patients continued their chronic urticaria treatment when they decide to become pregnant. It was only they changed their treatment or stopped their treatment when they found out that they are pregnant. But still, 60% of them were under treatment for their chronic urticaria during pregnancy, and most of them received standard doses of second generation antihistamines, while 5.6% received higher doses, but the higher doses generally included 2 times daily, twofolds, I can say. 7.6% used first generation antihistamines, while 5.6 patients used omalizumab treatment. And when we checked the outcomes of pregnancy, we found that the preterm birth rate and newborn medical rates were similar between patients who did and did not receive treatment during pregnancy. So we compared it with the ones who received treatment during pregnancy and did not receive during pregnancy. And also, we checked it with the normal general population who do not have chronic urticaria, and we saw that chronic urticaria did not cause more preterm birth or newborn medical problems. So the patients did not experience worse pregnancy outcomes. But what we found was there were two factors that were associated with preterm birth, and the one is twins, having twins. This is very expected. But the other one was important from our point of view. It was the emergency referral during pregnancy. So if the patient went to emergency for their chronic urticaria, that means that they have a higher disease activity, and the disease is not controlled. So we concluded that we need to keep urticaria under control during pregnancy to avoid worse pregnancy outcomes. So let's come to the topic: treatment of chronic urticaria during pregnancy and lactation. So the guidelines of urticaria, here you see, and I'm sure you're all familiar with this. The guidelines suggest that we use the same treatment algorithm, but with caution in patients with chronic urticaria who are pregnant and lactating, but we need to assess the risk and benefits. And for antihistamines, there is a huge meta-analysis which included almost 50,000 patients, and they concluded that the use of H1 antihistamines during first trimester is not associated with increased major malformations or other worse pregnancy outcomes. So the guidelines suggest to use loratadine with possible extrapolation to desloratadine and cetirizine with a possible extrapolation to levocetirizine during pregnancy. And also suggest to avoid using first generation H1 antihistamines. Although in our PREXI study, there was a high rate of first generation use during pregnancy. However, for the second generation antihistamines updosing, for the updosing, we don't have enough evidence. That's why the guidelines doesn't make a suggestion on this, and we need to be careful on updosing antihistamines in pregnant patients. So for omalizumab, animal data showed no maternal toxicity, embryotoxicity, or teratogenicity, even in 12-fold of maximum clinical dose. Of course, in monkeys, there were no adverse effects on fetal or neonatal growth. For the real-life studies in humans, there was a registry which is called the EXPECT registry, which was designed to compare the maternal and neonatal outcomes of asthma patients treated with omalizumab compared with patients who did not receive omalizumab. And so data was collected at enrollment each trimester and up to 18 months of post-delivery. And they found that there were no major differences between the patients with respect to worse pregnancy outcomes between patients who received and did not receive omalizumab during pregnancy. And there was no risk of major congenital anomalies following exposure to omalizumab. And there are several reports of the usage of omalizumab during pregnancy in CSU patients, in chronic urticaria patients, and they report successful use and with good pregnancy outcomes. And also there is a recent one which included 26 patients with chronic urticaria that were treated with omalizumab during pregnancy. This report from Italy concludes that omalizumab is safe to use during pregnancy. But important notes to remember: information of omalizumab during pregnancy is still limited, and we need to remember that omalizumab has a very long life of 26 days. And if a patient prefers that they don't want to have the impact of omalizumab during their pregnancy, they have to quit omalizumab treatment at least 130 days. That means 4.5 months before conception, because it can stay in the blood for a long time. And the second important point is, because omalizumab is an IgG type monoclonal antibody, and IgG1 has the greatest placental transfer, the lowest fetal omalizumab exposure occurs during the first trimester of pregnancy and greatest during the third trimester. So if your patient is very anxious, or if you are very anxious, you can give omalizumab treatment at the first trimester and then maybe quit it in the second and third trimester, so to be on the safe side, or if you are very anxious. But finally, the guideline says omalizumab treatment is safe and it's category B. So in severe patients, we can really continue using omalizumab treatment during pregnancy. So systemic steroids only we can use for short terms. Long term may cause problems like diabetes. And a steroid of choice should be prednisolone due to its short half-life and also it's effectively metabolized in the placenta. Cyclosporin is category C, but it's not teratogenic, so it can be used if it's really needed by the patients. And during lactation, antihistamines are safe to use, I can say, because the transfer rate to breast milk is minimal. Loratadine, cetirizine, and pegcetacoplan are the best studied and we can use. Higher doses is also safe to use during lactation. Converse to the knowledge of pregnancy. In lactation, they are safer in higher doses. And omalizumab is also safe to use during lactation because the amount in milk is very low and the absorption is very unlikely because it's a very big molecule and it doesn't transfer to the breast milk. Systemic steroids only transfer in minimal amounts, but we can suggest the patient to refrain breastfeeding for 4 hours after they took systemic steroids. Cyclosporin can still be used during lactation, but infants should be monitored, including measurement of serum cyclosporin and creatinine levels. So take home messages for pregnant and lactating patients with CSU. It is important to keep the disease under control during pregnancy, and guideline treatments appear safe to use during pregnancy. However, there is a lack of evidence-based safety information for sure. Loratadine, desloratadine, cetirizine, and levocetirizine are suggested to be used during pregnancy and lactation in patients with chronic urticaria by the guidelines. No safety data about updosing of antihistamines during pregnancy, and but for breastfeeding, the transfer to the milk is very low. Omalizumab seems safe for pregnancy and especially for lactation because it's a big molecule, doesn't transfer to the milk. But finally, we should always discuss risks and benefits with the patients and make a shared decision with the patients. But in the end, we should keep urticaria under control during pregnancy. So thank you for your kind invitation and thanks for your attention.
Hello, I am Dr. Kiran Godse from University School of Medicine, Navi Mumbai, India. I am a professor of dermatology and I'll be telling you about urticaria management and new guidelines. So, as you all know, urticaria is the disease which is common in almost 1% of the population. Urticaria guidelines are prepared in Indian setting as well as in the world setting, and they were published every 4 years. So new guidelines will be published in 2025, which were done in 2024. So we all know urticaria is a disease which is central swelling with variable size and erythema. It is associated with pruritus, burning and itching and resolves within 24 hours. If urticaria do not resolve in 24 hours, please think of urticaria vasculitis and biopsy is required. Tell the patient to take repeated photograph every 12 hours to see whether the lesions disappear. So as you know, urticaria is divided into acute and chronic. And chronic is further divided into spontaneous and inducible. Spontaneous urticaria have known causes and unknown causes. And commonest causes are autoimmunity, allergy, and infection. Inducible urticaria, the symptoms are induced by trigger, typically temperature, pressure, and cholinergic. Chronic spontaneous urticaria is defined as a spontaneous daily or almost daily itchy hives, angioedema, or both, lasting for 6 weeks and more. Any angioedema without urticaria, please think of hereditary angioedema, which is a rare condition. Otherwise, urticaria patients do have angioedema in almost 40% of the patients. So spontaneous urticaria are wheals of more than 6 weeks duration. Inducible urticaria could be physical or non-physical. Physical are symptomatic dermographism, cold urticaria, direct pressure urticaria, solar urticaria, heat urticaria, and vibratory angioedema. Non-physical are cholinergic, contact, and aquagenic. The emerging endotypes of chronic spontaneous urticaria are autoallergic and autoimmune. So we all know autoimmune urticaria, the two autoantibodies being IgG type, anti-IgE and anti-Fc epsilon R1. Autoallergic is autoimmunity type 1, where autoallergens play a part. I'll tell you a few of them, how to differentiate the two. So we all know that urticaria, the mast cell is the main culprit, which keeps on releasing mediators like histamine, tryptase, PAF, leukotrienes. And the mediators, the pathways are different. The commonest pathway is autoallergic or autoantigen, where Ig against self is the trigger. Autoimmune pathways are the traditional autoimmune type 2 autoimmunity, where IgE type, anti-Ig or anti-Fc epsilon R1 are the one, and they all pass through a BTK inhibitor, BTK pathway, and causes degranulation. And the emerging pathway is X2 or MRGPRX2 that also trigger mast cell to release histamine. So there are various pathways which can trigger mast cell to release histamine. Autoallergic type and autoimmune type, what are the differences? So typically autoallergic is auto IgE type against interleukin 24, TPO, thyroglobulin, DHDNA. Whereas autoimmunity type 2B is the IgG type against Ig or Fc epsilon R1. Diagnosis of autoallergic is by specific Ig to autoallergens or total auto Ig. Autoimmunity diagnosis is by autologous serum skin test or basophil histamine release assay or Western blot and ELISA. Typically, Ig levels are normal or high in autoallergic and low in autoimmune. Disease is less severe in autoallergic and more severe in autoimmune, and concomitant allergic diseases are common in autoallergic, and autoimmune diseases are common in autoimmune type. This is important that all patients with autoimmune chronic spontaneous urticaria may also have autoallergic type, but not vice versa. So there could have a combination of autoimmune and autoallergic urticaria in same patients, and that may give little problem in treating the patient. The different subgroups of CSU are linked to differences in laboratory and clinical features, which give us an idea whether patient has got autoimmune type or autoallergic type. Urticaria activity score is a validated score to assess the severity of urticaria. So each is classified as 0, 1, 2, 3, and hives as 0, 1, 2, 3. 1 is less than 20 hives, 2 is 20 to 50, and 3 is more than 50. So UA score of 6 is daily maximum and 42 in a week. So with this, we can actually diagnose the urticaria severity, like UA score of 28 to 42 is a severe urticaria, 16 to 27 is moderate, and 7 to 15 is a mild urticaria. Another test is urticaria control test. Patient has to answer 4 questions so that his last 4 weeks, how was his urticaria is we come to know, and total score of more than 12 means urticaria under control. So these UAs and UCT are the easier to do, and there's a cruise app available, freely downloadable for these tests. So urticaria duration is average 1 to 5 years. Typically, patient may have up to 25 years. 50% will resolve within 6 months of onset, 20% will resolve within 3 years, and under 20% will resolve in 5 to 10 years. Less than 2% will resolve within 25 years. Rarely, we can have urticaria up to 50 years duration. So urticaria is a long disease or chronic urticaria, and it affects almost 1% of the population. So all of us are going to see urticaria every day. The factors which suggest that these are the factors which can give the patient a severe urticaria, or those patients where the plain antihistaminics may not be useful, or you need a updosing or something more. So those having a severe disease, longer duration, females with age more than 50, concurrent angioedema or inducible urticaria, BMI more than 32, smokers, NSAID hypersensitivity, associated asthma, rhinitis, and polypharmacy. All these patients will have a severe urticaria which may last 5 years, 10 years or more. Why urticaria is a bad disease? Because almost half the patients suffer in relationship. They can't sleep well, they can't concentrate, they can't work normally, they become moody and irritable, and they stop or reduce doing fun things. So typically the disease affects almost all quality of life. So it involves every sphere of your life, be it physical, socio-economic, emotional, and psychological, and role function relationship. Every sphere is affected. That's why a meaningful patient-physician engagement is needed to support individualized treatment that addresses unmet emotional and holistic care needs, in addition to the effective control. So total control is important and long-term control is important to control the disease. Now, these are the guidelines which were formed in 2020. You start antihistaminics, one tablet. If no response, you make it 4 times. Second line is you start with antihistaminic. If no response, you add omalizumab. You updose omalizumab if no response, and add cyclosporine in the third line. You can always give short course of steroids if patient do not respond, but 5 to 10 days and not more. So these guidelines clearly tell us that antihistaminic is the first line treatment. But please remember, single tablet of antihistaminic is effective only in 50% of patients. You increase the dose, 25 to 30% patients will get control, but under 20% will remain symptomatic. When you add omalizumab, almost 20 to 83% patients get good response, but again 10 to 20% may not respond. And then you add cyclosporine to control. So there is no treatment is perfect. You need to add on treatment, and some patient needs a combination treatment to control the disease. Now, this is a new guideline just formed in December. They are not yet published. They are exactly same like old one, but here you can see they have added dupilumab, IL-4/13 antagonist, and remibrutinib, a BTK inhibitor. These two are added subject to they get license approval, because already phase 3 studies are there and they are expected to get approval in 2025. Rest all remains same. So typically the guidelines remain same: antihistaminics, omalizumab, and cyclosporine. And if patient can afford, dupilumab and remibrutinib is the answer. These are Indian guidelines where we say that standard antihistaminics are there, but here we say that you can updose 4 times. You can use combination of 2 antihistaminics. You can add H2 antihistaminics, and you can add montelukast also. And third line is omalizumab, cyclosporine, methotrexate, dapsone, and autoserum therapy in select number of patients can be used. So there are various options available because everybody cannot afford omalizumab or cyclosporine. So these options, they do work, but the evidence is less. So UCT will decide how long to continue. So UCT is a complete control of urticaria. UCT of 16, that means patient is complete under control. Don't try to reduce the antihistaminics. Try to reduce it slowly every 1 to 2 months. If urticaria is not controlled, you need to updose the antihistaminics or add omalizumab. So urticaria control test will give us an idea how well your urticaria is under control. Now, these are the indicators that which patient will respond to antihistaminics or not. Non-responder to antihistaminics, they have low quality of life, they have concomitant inducible urticaria, high urticaria activity score, high CRPs, high D dimer. Those who have got low total IG will respond better to cyclosporine. So response to cyclosporine is typically in those patients with a positive BHRA, basophil histamine release assay, or those with have treated with steroids. So cyclosporine is the third line or fourth line which works in these patients. Now we have a variety of antihistaminics available right from the chlorpheniramine till bilastine, the newest one, but typically we use the newer generation antihistaminic, that is cetirizine, levocetirizine, bilastine, fexofenadine, and cetirizine. We don't use estimizole, terfenadine, or chlorpheniramine. Not that they do not work, but they have got anticholinergic activity and they have got a sedative potential, which could be dangerous because patient's treatment goes long, up to 3 to 6 months or several years. Why we say the newer antihistamines are safe? Because the bilastine and fexofenadine are the one who have got the lowest brain receptor occupancy, so they do not penetrate the brain, so there is no sedation or less sedation, So these two are the truly non-sedating ones, whereas others like loratadine, cetirizine, olapatadine are mildly sedating, and chlorpheniramine and hydroxyzine are highly sedating antihistaminics. So sedating antihistaminics disturb the sleep architecture. REM sleep is delayed and reduced, and patient remains drowsy throughout. So don't advise routinely the older antihistaminic for the urticaria treatment. Omalizumab is a wonder drug. It's anti-IgE, prevents angioedema, improves quality of life. It's suitable for long-term treatment, and treatment dose is 150 to 300 mg subcutaneously once a month for 3 to 6 months. And now even a biosimilar is available, so which can be used those patients who do not respond to 4 tablets of antihistamine. But every patient does not respond to omalizumab. Those patients with BMI more than 32, aggravation of CSU after omalizumab, low IG, basopenia, high D-dimer, positive anti-TPO, these patients will take longer time to respond. So you have to combine with cyclosporine, methotrexate, or hydroxychloroquine. Cyclosporine is the immunosuppressive. It works directly on the mast cell mediated release. Again, you need to check CBC, creatinine, and blood pressure. You can start with the 200 mg first month, 100 mg second month, and 50 mg third month. And now there is a weekend cyclosporine therapy is can be used. You need to give 200 mg every Saturday, Sunday to control the disease. Corticosteroid 20 to 30 mg of prednisolone 5 to 10 days is permissible. Weekly pulse can be given in autoimmune type. Don't give betametrazone or prednisolone continuously. Methylprednisolone or deflazacort are the relatively safer with less side effects. How to work up the patient? Well, you need to differential diagnosis is important, rule of inflammation, and major disease activity. So these are the four things you must do in all your patients: CBC, ESR, CRP, total IG, and anti-TPO. By doing these tests, we can come to a conclusion whether the patient is autoallergic type or autoimmune type. IG is typically elevated in autoallergic type, where patient will respond better to omalizumab. Low IG, that is 20, 30, 40, or up to 100, is a low IG, which is the indicator of autoimmune type, and this patient will respond better to cyclosporine. So IG is a valuable marker, but don't repeat it every year. You can repeat if required. No repeated IG testing. CRP is linked to urticaria activity with inflammatory and coagulation markers. So high CRP level is sure shot. Patient will not respond to antihistamines. They will need something more, maybe cyclosporine or omalizumab. Five-part cell differential, basopenia is a well-documented indicator of autoimmune urticaria. You need a five-part cell differential, and absolute basophil count should be less, 0 or less, is the indicator of basopenia. Eosinopenia is also indicator of autoimmune urticaria type. Similarly, elevated mean platelet volume is an indicator of autoimmune type, and lymphopenia is also a marker of autoimmune type. IgG anti-TPO is a CSU autoimmune type 2. The positive indicates the autoimmunity. So positive anti-TPO and low IgE is a surrogate marker for autoimmune type 2 urticaria, and these patients will take longer time to respond. Beyond antihistaminic, they need a immunosuppressant like cyclosporine. What else you do? Avoid drugs. Three drugs you must important. You avoid NSAIDs, ACE inhibitors, and gliptins, which can trigger urticaria. Rule out infections. Do thyroid hormones and autoantibodies. A skin test. Rarely we do. Serum tryptase levels if there is severe disease or mastocytosis, and a biopsy if you suspect vasculitis. These are the extended diagnostic tests you do in these patients. Well, in every patient, you confirm the diagnosis, look for the cause, look for the cofactors, look for the comorbidities as autoimmunity and mental health is associated. Consequences, look for the sleep disturbances, sexual health, work, and social performance. Look for the components like biomarkers, and course of the disease, please do US and UCT to monitor CSU activity and disease activity. So this is algorithm. Any patient with urticaria or angioedema, please ask the important questions. Whether the patient got unexplained fever, joint pain, bone pain, malaise, think of autoinflammatory syndrome. If hives are lasting more than 24 hours, think of vasculitis. If symptoms are inducible, think of inducible urticaria. Angioedema, ask for ACE inhibitors. If patient is on ACE inhibitor, please stop it. If angioedema without urticaria wheals, think of hereditary angioedema. So this is the algorithm to understand whether patient got urticaria, urticaria vasculitis, or hereditary angioedema. Other options like Montelukast, ranitidine, methotrexate, mycophenolate, dapsone, sulfasalazine, autoserum therapy, and doxepin, they all work. Only thing is the evidence is poor, but all where resource poor setting, you can use this in addition to 4 tablets of antihistamine. Montelukast works in respiratory allergy and in NSAID into the urticaria. Dose is standard 10 mg per day and no updosing is advised. Antihistaminics, H2 antihistaminics, evidence is less, but you can add 150 mg of ranitidine or 20 mg of amoxicillin twice a day. It's a safe and economical option, and few patients do respond. So after 4 tablets of antihistaminic H1, you can add 2 tablets of H2. So this is my 7 tablet formula for urticaria. Those patients where you think that the treatment is not sufficient, please give 4 tablets of H1. That is 2 in the morning could be bilastine or fexofenadine, as they are less sedating. 2 in the evening are levocetine or loratadine. 2 H2 are ranitidine and 1 of montelukast. Please add vitamin D3 once a week for 8 weeks, especially it has a role. And B12, vegetarian patients can add 3 months of B12 supplement. Methotrexate works as immunosuppressant, 10 to 20 mg per week. Add folic acid and check TBC-LFT. It works slowly, takes 1 to 2 months to show the results. Mycophenolate mofetil, it's an antimetabolite. Dose is 1 to 2 grams daily. Dapsone works in urticaria vasculitis and in dilatation urticaria. Dose is 25 to 100 mg per day. Please do CBC and J6PD as dapsone-induced hemolytic anemia can occur. Autoserum therapy is a poor man's biologic. It involves parenteral or subcutaneous injection of autologous blood or serum in attempt to desensitize the patient to the urticaria factor. So typically 2 to 3 cc every week we give for 9 weeks. One-third patient do respond and many of the patients do like injection therapy. There are many references available which people can use it safely without any fear of side effects. Children, we use same algorithm, like start with half tablet, make it double. So standard dose, make it double and 4 times. Again, the strong consensus. So typically a levocetrazine or fexofenadine, you can start appropriate dose and then increase it 4 times. Pregnant and lactating women, the safe antihistamines are loratadine, levocetrazine, cetirizine, desloratadine, and fexofenadine. No updosing is advisable. So don't do updosing. And obviously, in pregnancy, urticaria may stay there or may disappear in one-third of the patients. So what's new in urticaria? Well, we have got newer molecules coming up. As I already told you, our new guidelines have added dupilumab and remibrutinib. Remibrutinib is a BTK inhibitor. Dupilumab is anti-IL-4 receptor antagonist. They work on mast cell. Obviously, it will take 1 to 2 years to come in the market. But till that, we have antihistaminic, cyclosporine, and omalizumab to treat our patients. So summarizing, second generation antihistaminic is the first line therapy. Omalizumab with updosing is second line, and cyclosporine is third line therapy. And a newer therapy is dupilumab and remibrutinib. So this is a cruise control app, easily downloadable. Patients can control their activity. Daily monitoring is easy, and USL UCP score is available. And there's an Indian Journal of Skin Allergy dedicated for urticaria and atopic dermatitis. You do log in and see. Thank you very much for patient listening.
Good day, dear colleagues, ladies and gentlemen. I would like to thank the organizers of the Guinea World Skin Health Day Congress, especially Professor Traore, to invite me to talk about patch testing, when and how. I work in Center for Research and Training in Skin Diseases and Leprosy, which is located in the central part of Tehran. This is the first skin research center established in Iran. We have various research and training units in our center, including tropical dermatology, immunodermatology, dermatoepidemiology, skin biometrology, trichology, and nanodermatology. In the immunodermatology unit, we visit patients with atopic dermatitis, contact dermatitis, and urticaria. I'm going to briefly talk about the contact dermatitis, about patch test and its indications and contraindications, the procedure of patch testing and how to interpret the results, false positive and negative responses of this test, the pros and cons of patch testing, and then at the end I will review the patch test studies in Iran, and finally a short take-home message. We have two types of contact hypersensitivity: contact dermatitis, which is a type 4 reaction due to delayed cell-mediated immunity, and contact urticaria, which is a type 1 reaction due to an immediate IgE-mediated response. Contact dermatitis is an inflammatory skin reaction induced by contact with chemicals. It includes 4 to 7% of all dermatological consultations, and it is especially important in occupational medicine because about 50% of all occupational diseases are contact dermatitis. We have two types of contact dermatitis: irritant contact dermatitis, which is caused by direct damage of chemicals to the skin, which induce a non-specific inflammatory response, so there is no memory T cell or no specific immunoglobulin. And the other side, we have allergic contact dermatitis, which is caused by a specific delayed type hypersensitivity to a contact allergen, and the patient develops specific memory T cells to that specific antigen. To compare these two, the prevalence of ICD is much higher. Clinically, the lesions in ICD are confined to the exposure site, but in ACD, they may spread and even make a generalized dermatitis. In ICD, the lesions develop in few hours or even a few minutes after the contact, but in ACD, it may take 12 to 72 hours for the immune response to develop the reaction. In ICD, it is caused by concentration above the threshold of the skin, but in ACD, it is independent of the concentration and even may develop after contact with very small amounts of the antigen. ICD can develop in everyone, but ACD develops only in sensitized patients. The prognosis of ICD is much better because after you remove the contact and treat, the patient improves. But in ACD, the prognosis is usually worse because the immunity develops in the patient and will be with him for the whole life. There are some tests to confirm the contact dermatitis and identify the contact allergen. The most important one, the patch test, and also its variations such as atopic patch test, photo patch test, and we have repeat open application use test, and also the lymphocyte transformation test. Okay, my presentation is mostly about the patch test. Patch test is the only scientific proof of allergic contact dermatitis. So without doing patch test, we cannot tell about the diagnosis of allergic contact dermatitis. So it is a diagnostic tool to identify the contact allergens, and the mechanism and the interpretation is different from other allergy tests such as skin prick test or blood tests, which usually identify the immediate allergies. Patch testing should be done in any suspected contact dermatitis, in occupational dermatitis, in recurrent or chronic dermatitis not responding to conventional treatment, in skin and mucous membrane eruptions in which delayed type hypersensitivity is suspected, such as drug eruptions or systemic contact dermatitis, in any dermatitis with unclear etiology, and also to evaluate the cosmetic products for the potential allergenicity. There are few contraindications for patch tests. Usually, if the patient have acute eczema or active skin infections, the patch testing should be postponed until the skin has been healed and cleared. In extensive skin diseases, because we need large areas, usually on the back, for doing the patch test, and also in pregnancy, as some allergens may pose risks to the developing fetus. How does it work? We apply a small amount of the suspected allergen on the skin, usually, as I mentioned, on the back for 48 hours. After then, the allergens are removed and skin reactions are assessed 20 to 30 minutes after removal. And also, there will be some delayed readings, usually at 84, 72, and 90 hours, 96 hours, and sometimes at 1 week after doing the patch test. What do we need for doing patch test? We need the allergens. We need a tape to put the allergens on the back, a highlighter to mark the margins of the test, a wood lamp to see the highlighters, and at the end, patient education forms for any of the positive allergens. Regarding allergens, there are more than 4,500 chemical substances which can cause contact dermatitis. So almost it is impossible to test all of them. The most common allergens are metals such as nickel, cobalt, chromium, fragrances, preservatives, rubber mixes, medications, cosmetic ingredients, and also patient's own materials. There are several famous screening series to begin the patch test. Some of them include even to 80 allergens. Some of them have fewer allergens such as true test or IVDK, which use about 28 to 30 allergens. In addition to the screening series, we have sub-expanded series which can be used in specified situations, such as allergens for the hairdressers, for the shoes, for the plants, vehicles, metals, antibiotics, corticosteroids, and photoallergens. And also the patient's own material can be used for testing with specific dilutions and vehicles. The allergens can be in separated syringes, which we put a small amount on these thin chambers and then apply it on the back of the patient, or we can use the ready-made true test, which the allergens are ready in tapes to put on the back. As you see, we put on the back, mark the margins of the test, and send the patient to home. After 48 hours, usually the patient comes back and we remove the allergens, and after 20 to 30 hours, read the skin reaction to any of them. This is the specific guideline for reading the patch test results. If there is no reaction, it is a negative reaction. If there is a faint macular erythema, it is considered a doubtful reaction. If there is erythema, infiltration, and few papules, it is a weak reaction or +1. If in addition to papules we see some vesicles, it is a strong positive reaction or +2 reaction. And if there is intense erythema, infiltration, and coalescing vesicles, and even bulla, it is an extreme positive reaction or +3 reaction. And if some necrosis or bulla or various morphologies is seen, it can be caused by an irritant reaction, which is marked with IR. So after doing the patches, what should we tell the patient? We have to provide the name of the allergens, usually the INCI names for the cosmetics, and also the allergens that might produce cross reaction to this positive reaction. We have to tell the patient where these allergens are present and how to avoid contact with them, the clinical relevance of these patch test results, and as I mentioned, the methods to avoiding the exposure, and names of suitable non-sensitizing substitutes if available. And these should be prepared in sheets, ready-made sheets to present to the patient. There are some challenges in the interpretation of the patch test results. Sometimes the patient shows multiple positive reactions, and which makes it difficult to distinguish between clinically relevant and irrelevant reactions. We may face with false positives, reactions that are clinically not relevant, but may cause unnecessary avoidance. There may be cross-reactivity between some allergens. So some substances may trigger reactions due to this cross-reactivity. And also sometimes there are atypical reactions with certain medications or when certain medications or systemic diseases can alter the response to the patch testing. False positive reactions also can be seen with borderline irritants such as metals, formaldehyde, and epoxy resin. And when we use concentrations beyond the irritancy threshold, or in patients with severe eczema, which show excited skin syndrome or angry back syndrome. We also may face with false negative patch test reactions when insufficient reproduction of the real conditions have been made, or if we fail to test proper allergens, or the concentration of the allergen is low, or due to improper test technique. Sometimes the patients show the positive reaction, as I mentioned, very late after 1 week. So if there is no reaction after 72 hours, it is recommended to have a delayed reading at 7 days. If we use inappropriate vehicle or the contact time is short, we may face false negative reaction. Also, some allergens need photo to be activated. So if we do not perform photo patch test, we may not detect these allergens. Corticosteroid and immunosuppressants may inhibit the patch test reaction. So it is recommended not to perform patch tests on patients taking more than 50 milligrams per day of prednisolone, and postpone the testing for at least 2 weeks after reducing the corticosteroid below this dose, or discontinuation of the use of the steroid. Also, if the patient have used a strong topical steroid on the back of the skin of the back, it may inhibit the patch test and produce a false negative reaction. Usually, oral antihistamines may be used, and they do not interfere with the patch test reaction. There are few side effects for the patch test. Very rarely, patient may be actively sensitized with the patch test when the patients did not have any contact with these allergens, but we have made this contact with doing the patch test. Also, it may produce irritant reactions, as I mentioned, with some allergens such as the metals, and also irritant reactions to the tape itself. It may produce severe multiple reactions in angry back syndrome when the patient has active eczema. It may produce ectopic flare of the eczema. It may produce Kebner phenomenon. Very rarely, a positive reaction may persist for several days or weeks, such as with gold. Very rarely, it may produce anaphylactic reactions or pigmentary changes at the site of the patch test. Pustular reactions may be seen as an irritant reactions. It may produce bacterial and viral infections, or very rarely result in necrosis, scar, and keloid. But these side effects are very, very rare. What are the pros of the patch test? It may increase the physician confidence, and the patients also appreciate the efforts to investigate their case and find the reason of their disease. Guidelines are available to avoid the complications, and several studies have shown that patients who were patch test positive and were instructed how to avoid contact with that antigen had a better outcome. The cons are this test need a large amount of time to do the test and to read, and then to evaluate the clinical relevance and educate the patient. It needs high number of visits. The suitable test materials are not available in all places. As I mentioned, there are some risk of complications, and also the financial concept because it is a relatively expensive test. The other test to evaluate allergic contact dermatitis is the repeat open application use test. It is a real life use test of the suspected allergens without any occlusion. The suspected allergen is applied on an area 5 by 5 centimeter on the forearm near the antecubital fossa twice daily for usually 1 week, and then the skin is observed for any reactions. The first study about allergic contact dermatitis in Iran was published in the Journal of Contact Dermatitis. In that study, we evaluated 250 patients from several parts of Iran with a clinical diagnosis of contact dermatitis, and we did the patch test with a 28 allergen series recommended by German Contact Dermatitis Research Group. About 50% of the patients showed at least one positive reaction, and 9% showed more than 2 positive reactions. 84% of these positive reactions had past or present clinical relevance, and the 5 most common allergens were nickel, cobalt, formaldehyde, potassium dichromate, and colophony. Contact allergy to nickel sulfate was significantly more common in female patients and in patients younger than 40 years of age. This is the result of patch testing to all the 28 allergens we tested. Another study, we evaluated the fragment allergy. We tested about more than 1,100 patients with a series of 30 allergens, and we found contact allergy to fragrance in 7% of them. Again, about more than 80% of these reactions were clinically relevant. The most common involved areas were hands and then face, and these fragrance allergy predominantly affect women aged more than 40 years. Then we evaluated in the same series contact dermatitis to metals, and we found that 27% of them gave a positive reaction to one of these metals. The most common metal was nickel, and then cobalt and potassium chromate. Nickel allergy, similar to the first study, was significantly more frequent in females and also in subjects aged longer than 40 years. On the other hand, chromium sensitivity was more common in males and patients aged over 40 years. And sensitivity to nickel or chromium was a risk factor for cobalt allergy as well. We evaluated dermatitis on eyelids. We tested more than 400 patients, and about 32% of them had eyelid dermatitis. So we divided patients in 3 groups: patients with only eyelid dermatitis, patients with eyelids and involvement of other areas, and patients without eyelid involvement, and compared these 3 groups. Nickel sulfate was the most common allergen in all groups, and use of shaving cream and hair conditioner was significantly higher in patients with only eyelid dermatitis. We have developed an online registry for patch tests, so any group doing patch tests in Iran can put their results in this registry and use this registry for future studies. So to conclude, despite some limitations, patch test is the gold standard test to make the diagnosis of allergic contact dermatitis. The choice of tested allergen depends on the environmental exposure of the patient. Experienced healthcare workers are required for application and reading the test. Timely discussion with the patient is required to interpret the test result, and it is necessary to provide comprehensive information about positive allergens to the patients, and also how to change the patient lifestyle to avoid contact with these allergens. At the end, I have to thank my colleagues in the centers who were involved in these patch test studies, and also thank you for your attention. It is the nation's gate in Persepolis in Shiraz in Iran. So all nations representatives were used to come at the first day of the spring to present their gifts to the king. I welcome all of you to come to and visit this nation's gate and other parts of Iran. You are all welcome.
Hello everyone. Good morning, good afternoon, and a very good evening. My name is Dr. Maimuna Sanistos. I'm speaking from Nigeria. I'm a skincare consultant and a dermatologist. I'll be talking about trachea on black skin under the Nigerian factor. Hope you'll enjoy my presentation. Thank you. We need to know what is urticaria. Urticaria is a kind of an allergic reaction that is common to almost everyone, particularly to those that are genetically inclined and those that have allergic kind of disorders. It could be a kind of disorder in many forms. In this presentation, we'll be exploring the presentation of hives, that is an allergic reaction, the cultural and social background and implication that will be examined on the Nigerian factor and to the society. Historical background on urticaria. The treatment of hives requires the history, that is the historical background, that is the vital of the patient, what makes him have the reaction, what influences it, the environmental factor, and the rest. Thank you. The recurrence of allergic reaction and the familiarity of it on black skin can be well explained and implied. The Nigerian factor, it's kind of common, particular, and specific, particularly on those that are affected by it. The issues of hives is highly related to those people due to other genetic factors and particularly to those that are fair in complexion. That is how allergic they are to such kinds of reactions. It is, however, noticeable that allergic rhinitis are over 22.8% in the prevalences of those that have other genetic disorders. These samples are people like have vitiligo, asthmatic patients, and the like. And I make a particular reference on the southern east of Nigeria and the northern part. Why? Because those kind of ethnic groups are mostly fair in complexion. It is notable to understand that allergic reactions in fair people tend to be more. Why? Because of the high melanin production, less melanin production, collagen production, hair is less than that of a darker person. Urticaria in black skin and the Nigerian context. We can see from the diagram below, we have serious allergic reaction on the first diagram, which shows that the person having the allergic reaction has some inflammatory effects. The second is a kind of eczema, and the third also some kind of historic reaction, meaning that the patient must have had a kind of disease that is underlying behind that causes the allergic reaction. Such kind of reactions should be outlined and known to what causes the reaction. Hives occur over 6 weeks or more on a patient or on someone. You don't necessarily have to be a patient to have an allergic reaction. Anybody can have one, particularly at the change of weather or food poisoning, or perhaps sometimes your body may not accept a certain kind of food or grain you've taken, so the body automatically reacts. Hives will occur over 6 weeks or more. Sometimes it comes just in a day or in a while and it goes away. But for those that have disorders, it might stay for a number of weeks, days, pending. What is it like to have an allergic reaction? This is not only a rhetoric question, but something that is quite disturbing to the person that has an allergic reaction. Such kind of hives or urticaria can come to a person in the sense that he could be very restless. Millions of sudden answers will come to this of what will happen to one if you have an allergic reaction. The best answer is to see a medical practitioner, a dermatologist on point, and then know what to do and go for the treatment your dermatologist suggested. Allergic reaction on the skin of color. The skin of color is a special kind of color and a very beautiful one. Particularly the black color, we have allergic reactions on various types. Some could be in hives, some could be less, and then the color really matters because sometimes if you're quite your complexion is really dark, on the Nigerian content, it is very common. On a darker complexion, it has to be examined well by the doctor to see it if it is not very prominent. But if it's on a fair person, even if you're a Nigerian, it will come out prominently. So it's comparable and it is treated differently depending on the type you have. History is important, then diagnosis, and then treatment comes in. There are various kinds of treatment to these allergic reactions. These treatments will go on the line with what causes it. The main causes could be weather factor, environmental changes, genetic factors, which are the main and major ones, hormonal changes, air pollution, unclean water, it could be dirty, lack of good hygiene, and unhealthy eating habits. Because sometimes when you drink water that is quite dirty or uncleaned, you could have some allergic reactions. Overweight at times do cause that also. Health line, which I mentioned, which means you need to see a doctor, go to a healthcare professional, go to see a dermatologist, and then have some medications, know what to do, and know what changes and what gives you the allergic reactions. When to see a doctor is important. It could be monthly, weekly, it all depends. When you have it, immediately see your physician. Antihistamines are also important. When you have an allergic reaction, your doctor will prescribe what is required for you. And then there is this psychological aspect because it disturbs anyone that has it. Anybody with an allergic reaction is really disturbed. It's quite irritating. It can make one sad. At times, it can make one be isolated. So that is the psychological aspect of it. How do we diagnose urticaria, that is allergic reaction on the black skin? We have various ways. One is biopsy, the doctor's assessment, skin snip, and then under a microscope. Sometimes the doctor can be able to identify which kind of urticaria one has. The picture below on the diagram shows a pustular psoriasis on the darker skin, urticaria psoriasis. All these kind of disorders have a kind of way the allergic reactions, the urticaria, comes on the patient, which will be treated accordingly by the doctor. Treatment on the urticaria, once again, it differs from one person to the other. Hives will often go away by using home remedies. Be sure you're using the right ones, the clean ones, and in proportion. And then your doctor's advice, your doctor's medication is important. As a doctor, most allergic reactions undergo the treatment of hydrocortisone injection. For an adult, it's about 100 milligram for a start, and at times it goes for 3 to 5 days. And then for a child, the weight, the age has to be known, and then you prescribe. We also have other antihistamines like loratadine and pregabalin, which will go according to the hives and then the age of the patient. We have other remedies, which are salicylic acid, which is from a natural source, and then the phototherapy. The phototherapy is very important, especially to the adults. You either undergo the real phototherapy in the hospital, or you go under the morning sun, which starts usually from 9 o'clock or from 8 to 9. And then other treatments goes along with taking fruits and vegetables, including exercises. We have before and afters of urticaria, which some of the patients from SSVC Skincare Clinic, of which I'm the CEO, had undergone a series of medication on which the patients are better. The first patient here with the fingernails is a child of about 7 years of age who had gone under some allergic reaction of lack of vitamins. After the vitamins induction, B12 and others, the patient got better within a period of a year. And the other one has contact dermatitis. Within just a period of around 6 to 7 months, the patient got better, but not completely because it's an autoimmune disorder. It is important under the treatment of allergic reaction, go along with your utensils, with your essentials, in your bags, in your traveling bags if you're traveling. And even if you're at home or at work, know what to do and what to take. Family factor, that is the main genetic important thing about allergic reactions. Some heredited it, they get it from the parents or the parents or the extended family. It all depends. That is a patient being genetically inclined. A case study from my own family, that is the Sanistus family. I examined and I took a data of the whole family, and we realized that 54% of the female children from my family have major constant allergic reactions, which sometimes part of this 54%, around 30% have hives, that is urticaria. The male in my family have about 33. The main genetic disorder that we have is psoriasis. Total number of patients in my family with hives is about 30%, like I mentioned. This data is taken from the 22nd of November 2024. Another data was taken from SSBC Skincare Clinic, which we have the record implied. Yes, chronic disorders and other skin conditions like diabetes can cause hives. Survey on patients with allergic-related cases in Kaduna State. One was a tertiary institution, which I took a questionnaire to. Unfortunately, we have a kind of an I don't care attitude on the Nigerian factor. Basically, in the northern part of Nigeria, a lot of people cared nonetheless about their skin. So the form we took to the institution, out of about 139 students, we were only able to get about 13 students that filled in the questionnaire. 4 patients with serious urticaria, that is allergic reaction. And then in a general hospital, we were only able to get just 2 patients. On a private clinic, the overall result is just about 5%. Another survey was taken in the northern part of Nigeria in a particular state, apart from Kaduna State, which the data is mentioned below. Another survey is taken from Katsina State, which is quite interesting. This is a northern part of Nigeria, which is a hot area. So much of the patients that are genetically inclined have serious hives because the skin is usually dry. And from the data gotten from a general hospital named Babaruga, we have about more than 80% in a month case of urticaria. All this are the data collected, and the numbers and figures have been explained already. It is important to know that allergic reactions are connected to hives, urticaria, name it. We have them in various forms, and it is important we take care of it through going to see a doctor, going to the hospital, taking care of your skin. It can be in so many forms. You're taking medications. It can be in homeopathic order, in the sense that some people believe in Chinese medicine. Homeopathy is a kind of medication that a patient tests himself with a kind of fruit or food, and then your body will react to the kind of food it likes, and to some it doesn't. Then you go after this if you're comfortable with it. The dermatologist appointment is important. We need to know the skin health is important more than any other thing. So it's important we take care of our skin. Thank you.
Good evening, everyone. I'm Dr. Henry Fong. I'm a dermatologist from Ipoh, Malaysia. First of all, I'd like to thank Dr. Ibrahim for the invitation to speak at this meeting. I'm going to talk about pathogenesis and management of chronic spontaneous urticaria. At the end of this short lecture, you should be able to understand the definition and classification of urticaria, the pathogenesis of CSU, chronic spontaneous urticaria, how we manage CSU, and what's new in itch and CSU. Chronic spontaneous urticaria is a very classical picture of patient with urticaria, defined as presence of erythematous wheals or hives of 6 weeks duration or more. So the cutoff point is 6 weeks. And the urticaria usually transient less than 24 hours and may be associated with angioedema in about 1/3 of cases. And it excludes physical urticaria, for instance, from heat, exercise, cold, or pressure, which is called CINDU, what they call it, chronic inducible urticaria. And CSU is a clinical diagnosis in which itch is the main central symptom. These are examples of urticaria. For instance, on the left, you can see pictures of urticaria. In fact, we call it dermographism, where you scratch on the skin, the lesion occurs on the area where you scratch. And sometimes patients with severe urticaria need to be admitted, like for instance, you see on the right-hand side, severe urticaria needs admission and requires systemic intravenous steroids for the control of severe urticaria. Angioedema, on the other hand, means sudden swelling of the lower dermis and subcutaneous fat. It's a submucosal swelling. As you can see from the slide here, this patient with angioedema is asymmetrical and is painful or discomfort more than itch and involves below the mucous membranes, and in fact, mainly the face, periorbital area, perioral area, sometimes genitalia, extremities, and occasionally even within the oral cavity, the tongue, the pharynx, the larynx, and bowels can be involved. In contrast to urticaria, this takes a long time to clear and usually can take up to 70 hours for clearance. Urticaria is based on its duration, okay? So if it is 6 weeks or less, we call it acute urticaria. And if it is 6 weeks or more, we call it chronic urticaria. Causes of acute urticaria, most of the time the cause is unknown, but 35% believed to be due to infection, especially viral, drugs, IV contrast, blood transfusion from food, and as well as insect bites. Chronic urticaria, there are two types of chronic urticaria. CSU, the spontaneous type, for about 80% of chronic urticaria, and the inducible type, CIU, 20%. About 1% of population is affected, and that's the female predominance. The age usually about third and fifth decade, and can last for even a duration of 2 to 5 years. So you can see that CSU is a common disease worldwide. 86 million population suffers from CSU. And basically, they are found mainly in Latin America as well as in Asia. This is an interesting study, a systemic review with meta-analysis, looking at the overall CU prevalence. They look at all the population-based studies, and in this, they involve 11 studies, meta-analysis, 86 million participants. They again found that female is more common than male, and in children, female equals to the male proportion, and the prevalence is more common in Asia, 1.4% compared to Europe, 0.5%. Patients often experience long delay in diagnosis and correct treatment. For instance, in South America, it may take up to 3 years for diagnosis of chronic spontaneous urticaria. What's the pathophysiology behind chronic spontaneous urticaria? Urticaria is a mast cell-driven disease. I repeat again, urticaria is a mast cell-driven disease, unlike atopic dermatitis, psoriasis, which is mainly a T-cell disease. It gives rise to a lot of histamines, a lot of cytokines, as well as platelet activating factor, and this gives rise to effect on the sensory nerve activation, vasodilatation, as well as plasma extravasation. And the urticaria response actually resembles a wheel and flare reaction. A paper by Malcolm Greaves, 2013, on the pathology and classification of urticaria. I think this paper is interesting. It's among the first paper to look at urticaria from the pathology and classification. In this particular paper, he classified chronic urticaria as either chronic spontaneous urticaria, autoimmune etiology or unknown etiology, the idiopathic type. Any chronic inducible urticaria can hold lists of physical urticaria, plus or collinear urticaria, as well as contact urticaria. Skin biopsy is not routinely done in urticaria, and we only do skin biopsy unless it's a diagnostic problem or you want to differentiate from urticaria vasculitis. If you do a skin biopsy in urticaria, you find that the pathology is mainly on the dermis. You may see very minimal upper dermal edema and some perivascular infiltrates of lymphocyte neutrophils or neutrophils. Whereas in urticaria vasculitis, you see a loss of neutrophils on the vessels, extravasation of red blood cells, fibrinal necrosis of vessel, what you term as leukocytic vasculitis. Types of CSU, there are two types of CSU. There are type 1 autoallergy, the presence of IgE, autoantibodies against autoallergens. And the second type is a type 2B autoimmune. These are IgG, autoantibodies targeted the mast cell receptors, the Fc epsilon receptor, and the anti-IgE. So what is type 1 autoallergy? These are IgE antibodies against autoallergens. There are many types of autoallergens. Among them are the thyroid peroxidase, the thyroglobulins, the tissue factors, IL-24, and so on. And these IgE antibodies are produced by B cells, and the IgE antibodies then induce mast cell degranulation. The thing is, IgE antibodies to this autoallergen are not routinely available. So what we do in a clinical practice, we measure the total IgE levels, which may be elevated, and the thyroid peroxidase or thyroglobulin antibodies. Type 2B autoimmune, this is IgG antibodies in contrast to IgE in type 1. IgG antibodies against either IgE or the high affinity Fc epsilon R receptors. So these IgG autoantibodies then degrade mast cells, okay, giving rise to all the effect of histamine and various cytokines. And remember, eosinophils can also activate mast cells by this same mechanism. So type 2B autoimmune are associated with autoimmune disease, tend to have higher disease severity, more severe, and then have lower IgE level with high titer anti-thyroid peroxidase antibodies. And they may be associated with basopenia and eosinophilia. Now we know that CSU is related with some kind of comorbidity. There is definitely a high incidence of thyroid autoimmunity, right? There are also other autoimmune disease like vitiligo, pernicious anemia, rheumatoid arthritis, which is a higher incidence when you have a patient with CSU. Now, this slide shows you the role of IgE, okay, IgE mast cells in CSU. So this is the resting mast cell. You have the Fc epsilon receptor here sitting on it and the IgE, okay, over the receptors here. And what happened is there are three ways of activating the mast cell. You can have the antigen sitting on the IgE receptors here, yeah, and this is what I call the self-antigen giving rise to your type 1 autoimmunity. And you have the other way is your IgG and antibody against your Fc epsilon receptor here, or your IgG against your IgE, giving rise to mast cell degranulation. Very interesting paper looking at the autoimmune chronic spontaneous urticaria, the type 2 type. Okay, the biomarkers and clinical characteristics. Here, the aim of the study is to define characteristics of autoimmune CSU done in 12 centers in 10 countries. Look at 182 CSU patients. They define autoimmune CSU as presence of mast cell degranulating IgG, autoantibodies to IgE, or the high affinity receptor F epsilon receptor. And these were the diagnostic criteria. So in this particular study, they looked at this particular group have a lower total IgE, 22 versus 102. They have a higher urticaria activity, US 7, 21 versus 9. And other autoimmune parameter, example, your IgG, anti-thyroid peroxidase, were higher compared to the other type. And patients with low total IgE and high IgG anti-thyroid peroxidase are likely to be the autoimmune type 2B. Now remember that in clinical practice, we see a lot of patients with urticaria. Not all urticaria lesions are urticaria. Okay, so this is an example of differential diagnosis makers of urticaria. Urticaria vasculitis. Patient will have symptoms. The urticaria lasts more than 24 hours. Please consider referring to the dermatologist for skin biopsy. Patient with burning sensation, with post-hyperpigmentation. And there's an entity called the urticaria pemphigoid, seen in bullous pemphigoid, the pre-bullous stage. They may look very similar to urticaria, but then it'll be bullous pemphigoid. Mastocytosis, also known as urticaria pigmentosa, near the Darius sign. When you stroke on the lesion, all right, the lesion get exacerbated. And the serum sickness-like reaction, type 3 drugs, hypersensitive reaction with fever, rash, arthralgia, give rise to urticaria lesion-like. So this slide shows you the different types of urticaria, urticaria vasculitis, right? On the left here, you can see the PIH, urticaria, ordinary urticaria, and the bullous pemphigoid before the blister stage. There's something called autoinflammatory syndromes. It's important to diagnose them. And this patient have, apart from urticaria, they have recurring fever and arthralgia, okay? And the reason why you need to diagnose is because the treatment is not systemic steroids. You have to consider using IL-1 blocker like anakinra to successfully treat this particular group of autoinflammatory syndromes. So this is a landmark article, the IACI guidelines on the definition, classification, diagnosis, and management of urticaria published in the Allergy Journal 2022. And basically, the working hypothesis on the pathogenesis of urticaria as outlined in this particular guideline. So you have the modulators on top here, stress, foodstuff, drugs, infections, okay? And you have degranulators here, all right? Giving rise to all your the effect of the histamine, okay, and various cytokines, all right? Believe that the top part here give rise to acute urticaria, and your bottom half here explains the mechanism of chronic urticaria. So what's the goal of treating patients suffering chronic urticaria? Keyword is absence of symptoms, absence of symptoms. You treat the disease until it is gone. So we recommend aiming at complete symptom control in urticaria, consider as much as possible the safety and quality of life of each individual patient. Two things you must remember: learn how to assess the disease activity, what we call UAS7, looking at two parameters, the views and itch, and all given scores, 3, okay, each. And they total up for over 7 days, giving a maximum of 42. All right, patient with UAS7 of 15 and less are considered mild urticaria. Then you have the urticaria control test, also known as UCT. You can see here the various ways of calculating UCT. For instance, you know how much you have suffered from symptom urticaria over the last 4 weeks. Then give a score, and total score maximum is 16. And if your UCT is less than 12, means your urticaria is not well controlled, you may require to step up the treatment. In terms of laboratory tests, no laboratory testing is necessary for individuals with unremarkable history of physical finding. Basically, you do not require any blood tests, you know. And chronic spontaneous urticaria actually is a clinical diagnosis. If you really want to do lab tests, it's very limited for reassurance value. You can do a full blood count, your CRP-SR. You can check your total IgG level or your TPO level antibody. All right. The rest of these tests we hardly do in our clinical practice. And this is the guidelines, 2022 revision updated. I think most of you are aware of it. The first one is your second generation antihistamine. Okay, if needed, you up dose to 4 times daily. Okay, and if this fail, then you may consider adding omalizumab 300 milligram every 4 weeks. And needed, depending on the control, you can up dose. Okay, either increase the dose or shorter interval. If that doesn't control, you can add on your cyclosporine. I must say, in my country, because of limited resources and omalizumab is not cheap, expensive, we do not step up so quickly. So fail of antihistamine, you may consider drugs like montelukast, at least by time, whether hopefully it will control. Then you don't have to use expensive drug and able to cut costs. So non-sedative modern second generation antihistamine are the first line treatment. So which antihistamine do you recommend? There's no ideal antihistamine here. All right, you can see you have various groups here: belastin, fexofenadine, cetirizine, levocetirizine, and so on. But by and large, usually I choose either belastin or fexofenadine. They are non-sedating and they're very little drug interaction. Very little drug interaction and safe to use in renal impairment and liver impairment. So that's easier for me to to use the medication in my practice. Refractory urticaria not responding to antihistamine. We have mentioned that earlier on. All right, omalizumab. There are a few other drugs we can use, dupilumab and remibrutinib, which I'm going to explain later. You can see a whole list of other drugs that can be used. When you refer to a dermatologist, refractory urticaria not responding antihistamine, I think you should refer to a dermatologist for further evaluation and further treatment. Injury lesions that persist beyond 24 hours where you suspect urticaria vasculitis, you should refer to the dermatologist for biopsy and proper management and look at what's underlying cause of the urticaria vasculitis. Patient with diagnostic problem and patient with steroid side effects, I think you should also refer to the dermatologist. So what's new in CSU and itch? This was an interesting study in 2017, kind of set our thinking about, the sensory neurons express type 2 cytokine receptors. Type 2 cytokine receptors are your IL-4, IL-13, IL-31, IL-5. And this particular study done by Owen in Brian Gibbs' laboratory, they were actually able to show that, in your sensory neurons, there are receptors sitting on it, your IL-4, 13, and 31. So now we know that each is encoded at two major neuronal pathways. You have the histaminergic pathway, all right? Histamine, okay? You have H1, H2, and H4, but you also have the non-histaminergic pathway. We explain why certain patients with, especially atopic dermatitis, why each is non-histaminergic. All right, you have cytokines here, IL-4, 13, 31, 33, proteases, peptides, leukotriene, and other mediators. Yeah, okay. And of course, we know that omalizumab in this particular landmark article shows a very excellent response to treatment of chronic spontaneous urticaria, which make it FDA approved for CSU. Now, dupilumab is another new drug, okay, which can be used. This is a trial, chronic spontaneous urticaria called the Liberty CSU study, Cupid study. There are two randomized double-blind placebo-controlled phase 3 trial. Here, study A, study B. Study A looks at omalizumab naive. Study B looks at omalizumab intolerant or incomplete responders. What they found was interesting. Dupilumab works better compared to placebo. All right, in both groups, A and B. But it's only in the B group, which is omalizumab intolerant incomplete. It works better, but it did not reach a significant value. So what's the rationale of using dupilumab in chronic spontaneous urticaria? You can see here from a diagram right here, the mast cells, and these are sensory neurons here. Dupilumab with no block IL-4 receptor, alpha receptors, reduces the type 2 cytokines signaling upstream. And this actual reduction reduces the neurogenic inflammation, okay? Hence prevents overactivation of mast cells from the nerve. And we now know that IL-4 and IL-13 are important for mast cell activation. This slide shows the interaction between mast cells and the sensory neurons here. Look at this here, okay? Mast cells as a model for neuroimmune interactions responds to various neuropeptides, mast cells, okay? And release a plethora of each mediators to release pro-inflammatory molecules that exacerbate inflammation like substance P. This diagram shows the mast cell O activation and neuroimmune dysregulation and edema in CSU. You can see that unlike atopic dermatitis, which is an epidermal disease, chronic spontaneous urticaria is a more a dermal disease. You see most of the changes happen in the dermis, right? This is a mast cell media release, okay? And here are the effects from the brain, your neurons, neuropeptide release, okay? Neuroactivation and sensitization. And the effect of this media release causes validation, and this causes cell recruitment, and the cycle goes on, all right? Same thing here, type 2 cytokines perpetuate CSU pathology through diverse processes. These are mast cell activation and degranulation, all right? Through various inflammatory mediators, causing views, okay? And this all your type 2 cytokines stimulate your various kind of cells and then give rise to this cycle again, okay? At the same time, the mast cells activation also give rise to neuropeptides, which cause neurosensitization, and this cell neuron give rise to the itch. So coming to the end of my talk, BTK, Bruton's tyrosine kinase inhibitors, a very nice article, 2021. We're going to read more about how BTK inhibition, okay, can give rise to the therapeutic condition. And here is BTK, right, sits right here in the mast cells. They are kind of downstream from the receptor, Ig receptors here. So you block here, you block the release of all the various histamine, the cytokines. And the prototype for this BTK inhibitor is the remibrutinib, okay? Interesting drug. You can use orally, but it's not available in Malaysia yet. So I will not elaborate on this, but it's interesting. It's effective in patients with chronic spontaneous urticaria. So urticaria is a mast cell-driven disease. CSU has at least two different inflammatory pathways, the autoallergic and autoimmune. And remember, evaluate disease activity, you can use UAS7 or UCT. And the second generation non-sedative insulin are still the mainstay of therapy. And you can increase the second generation H1 antihistamine up to 4 times, or you can use other medicine like dupilumab, omalizumab, and cyclosporine. Thank you very much.
Dear colleagues,
Hello, everyone.
Good evening, everyone. I'm Dr. Henry Fong. I'm a dermatologist from Ipoh, Malaysia. First of all, I'd like to thank Dr. Ibrahim for the invitation to speak at this meeting.